Hello, and welcome to the Texas System of Care Cultural and Linguistic Competence Podcast. My name is Shannon Moreno, and I'm the CLC, or Cultural and Linguistic Competence Specialist with Texas System of Care. This is the second episode of our series focused on working with African-American youth and their families. We continue our conversation with Dr. Regenia Hicks, Juvenile Probation Officer in the Health Services Division at Harris County Juvenile Probation in Houston, Texas. In regards to the strengths of the community, could you speak to or, give any examples of how behavioral health clinicians can try to tap into those strengths? So we were talking before about how many different systems, but including the mental health system, is not necessarily set up to automatically honor the strengths of the African American community. It's more set up to honor the strengths of majority culture or the norms of majority culture. Given that, what can clinicians do kind of like at a practical level to make sure that they, as individual workers, are paying attention to the strengths of the families that they're working with?
Right. One of the things that come to mind for me is the fact that there are certain, what do I want to call them, loaded words that may have different meanings by virtue of the community that you were working with. To give an example, as a clinician, we use the term enmeshed, that this is an enmeshed family system. And that enmeshment means that people are all kind of not respecting boundaries, and they're kind of crossing roles or the like. That's something for me that comes very much, terminology that can come very much from a major majority or from what we might call the European perspective. Because within other families, and particularly within some African American families, just as I had talked about before, not having more flexibility around roles or who the people are that you depend on and how those relationships form by virtue of what's needed for that individual family can be very different. And so I think it's real important to not necessarily, as you're looking, be so eager or quick to place a name on something that could be seen very differently based on who that family is and what their reality is like. And I think that in general, part of our training as clinicians is to be able to listen and not rush to judgment. But I think particularly when you're in the situation of working with a family that is different from you, you really want to have your listening ears on in a much more acute way and listen to what those things are and why those things or those relationships and the exact characteristic or tenor of those relationships could be very different than another group or individuals that you might be working with. And so that's just one of those things that comes to mind for me. And I think that some of your other points are very much connected with that as well. I think it's always important to feel comfortable in a clinical setting, to ask people and to acknowledge that there are things that you don't know. I've never been, or part of my training and the people that I've worked with has never been one that has put ourselves as clinicians as being all-knowing and all-seeing and all of that, but that it's okay from the humanistic perspective to show a level of what someone might see as vulnerability. But for me, it's just being human and saying, I'm not sure I understand that, or I don't know that. Would it be okay if you would tell me exactly what it is that you mean by that? I think it's better to be able to be comfortable to ask certain questions that you might not be sure of than going into a situation and making a judgment or a conclusion without completely understanding what it means in the context of that family and what their experiences have been like within the broader world.
Absolutely. And I think that cultural humility piece that you're talking about is going to be forever ongoing, for every person who is providing services or interacting, with their local community. That's always going to be a piece, regardless of, how many trainings you go to or anything like that. That's why, cultural competence is a little bit of a misnomer, because there's not a certain bar that you can reach to where you've arrived, and there's no reason for continued learning. Everyone needs to continue to learn in their individual professional journey. But especially having that kind of cultural humility radar up, if you're someone who knows that you really throughout your life have not had a whole lot of interaction with members of a particular population, or if the only interactions have been within a particular context, maybe in your personal life, you haven't interacted with African Americans a whole lot, then in that situation, you particularly really need to have your cultural humility radar up, to where if you're starting to think that a family is quote unquote non-compliant, or quote unquote, as you mentioned, Dr. Hicks, enmeshed, that there could be cultural differences going on here. There could be bigger societal issues at play here. So I think that is great to point out. Could you talk? I'm
if I
sorry.
could just jump in terms of just the whole term of cultural competence. Having had the opportunity of working with some of the people at the federal level that originally worked on that whole definition and notion, I think one of the things that maybe has gotten lost over time is that level of competence that was being talked about was really not saying that you are at the level of knowing all, but it's really talking about the things that you do know, and that part of the competence is really pushing yourself to continue to be on that path of learning that you just identified, which is all part of who we are as humans in general. I know for me, having had the opportunity of working in different trans-cultural situations, there is always something left to be learned, but it's basically having that level of self-knowledge, being able to put the mirror up in front of your own face and feel comfortable again with who you are, knowing what your culture is, knowing where you might have some of your own differences or biases, even, which we all do, because because that's just part of us being human in terms of that, and being able to identify those things and separate it out. So you are constantly on that path again of learning something new. Right now, I'm here in Houston. We have a very sizable population of Nigerian immigrants, people that originally came over as for work, and now they have their second generation of children here. And what we're seeing is the what I want to say, the intercultural conflict that happens always when you have come in where you've come from a very strong cultural direction, and now over time, the children are starting to identify more with the dominant culture. And here within the United States, it's some of what with the youth might be part of the music or things like that, and the dress, which is very different from what their families of origins have seen. So we have people now that are seeking out a level of understanding through individuals that we call as being cultural brokers or cultural guides, of helping them to understand what this particular behavior means, coming from that perspective of someone who was born in Nigeria but whose children are now educated in the U.S., and how to help start bridging that gap that now exists between it's a different level of intergenerational conflict, I guess I'd say.
Yeah, absolutely. Thank you so much for bringing that up and talking about that issue. Could you speak, Dr. Hicks, to some specifically diagnostic concerns, perhaps common areas where African American children and adults as well may get misdiagnosed or may not be being diagnosed with a behavioral health issue when it could be appropriate? What are some common concerns that you've seen there?
Well, historically, there is a lot of data that specifically points to the fact that there, in terms of clinical diagnoses, there has always been over an overdiagnosis of schizophrenia in African American populations or in black populations, and kind of the underidentification of bipolar disorder. And so, again, for me, in some ways, if you look at which one of those definitions is seen as being more workable, clearly the definition of somebody having a definition oftentimes of bipolar disorder where it's very amenable to medication, treatment, and certain types of supports, versus what in the past we had seen with schizophrenia, and we have seen a lot of changes in terms of medications and different types of interventions within that population as well. But that is something that we have tended to see for years in terms of that. As far as looking at diagnoses, that particularly in young males, there's always been the underidentification of males of color in general, but right now talking about African American young men as being diagnosed as being depressed versus them being seen as having a conduct disorder or being seen as having attention deficit with hyperactivity, whatever. And so again, it's looking at the behavior from looking at those as it being something that's very external in some situations versus what's happening as internally, or that this could have a neurobiological basis. Years ago, when I was doing some training with residential treatment providers, one of the things that I did is that I developed a vignette of a young male, and the only thing that was different about the clinical description was just the fact of the color. And within that situation, it did play out that they were looking at this as being a conduct issue or other things, that there was some aggression there, but there was also a lot of periods of sadness and the like. But because, again, of how we have been acculturated within our society based on, and some of that acculturation also coming very much from what we see on the outside in terms of the media presentations, it's not unusual that is still something that tends to be predominant for many folks as they're looking at diagnoses. I think that just the fact that people are now becoming more aware of that has happened to make a change. The fact that we know that there are other what we call culture-specific or culture-bound disorders that you see in other ethnic or cultural groups has really helped us to have a better understanding of that as well.
Absolutely. And so something that clinicians can be on the lookout for is specifically, as you were saying, in regards to, young boys of color, young men of color who have maybe previously been diagnosed with a conduct disorder, or, maybe a listener is a clinician who performs diagnostic assessments, and if they're on the road towards diagnosing a young person with a conduct disorder, to maybe pause and reflect for a moment and try to see if maybe there could be an issue of depression going on with this young person. I think that would be a very powerful thing. Mm-hmm. And even for listeners who maybe aren't necessarily clinicians, but are potentially in a position to advocate for young people who they work with, that that is something that is really, really important to know about the high rates of conduct disorder that are assigned to young men of color, whereas their white counterparts would probably be receiving a different mental health diagnosis, and all of the kind of stigma that follows a young person throughout interactions with various systems by having a diagnosis of a conduct disorder. It's kind of a snowball effect can take place in that situation. So I think that's a very, very powerful piece that you brought up, Dr. Hicks.
My early training as a clinician was, like for many people, was very psychoanalytically oriented, and I think that there's a good basis for, just for looking at that in some ways. And one of the things that we were trained on was the whole concept of what was called mass depression, in terms of that there are other very outward signs of someone attempting to mask the fact that they are depressed, and how people can miss that. And I think when you see particularly many African-American males and some African-American females, particularly those youth that you're going to see part of the juvenile justice system, or the youth that are being referred through the education system, or even in child welfare, many of whom may also be part of you might see that class dynamic adding there, that there's a level of bravado, or the kids now are calling it swagger, but a level of bravado that, because of where they're coming from in terms of their individual community, that it's not okay to show that you may be having these feelings of being sad. I mean, that means that you're not strong, and being able to show in many communities that are, particularly those that are plagued with a lot of community violence, that can be seen as a level of weakness. And so kids are going to do everything that they can not to show that in many environments, when it really is something that is really happening for them intrapsychically.
Absolutely. And it's very easy to see where if a worker does not have that understanding, they can really, really misread, what messages the youth is trying to put out there.
I hope you enjoyed today's CLC podcast. If you have any questions on how to bring CLC initiatives into your local system of care community, please feel free to email us at info@txsystemofcare.org.